2021, and we're going to be performing a Deuk Laser Disc Repair in the lower back for chronic back pain, somebody with pain in the back for a long time, and they have 3 herniated discs, among other things. And the reason I say 3 herniated discs among other things is the herniated discs are the source of the pain. It's specifically the annular tear in the back of the disc that's causing their pain. But they have a lot of other findings that you would note if you looked at their MRI report or X-ray report. Findings that include things like spondylolisthesis, which is a slippage of bones, and stenosis. And these things are not causing the back pain, so we're focusing on what is. Our patient is, of course, is awake. We're going to put you to sleep soon, but I need you awake in the beginning, okay? All right, can you hear me? First thing I'm going to do is give you some numbing medicine to numb your skin up so it's more comfortable for you while we get started. We're going to put you to sleep in about 10 minutes, but I need about 10 minutes with you awake to help me out. We need to drop the pressure. It's important you don't pick your head up, but you lay still, okay? You don't move around. All right, if you feel any pain and you want to move, you just say, ouch, I'll stop what I'm doing and I'll give you some more pain medicine, okay? All right, you're doing fine. Everything is fine right now. So our patient is, she comes from Canada, as a matter of fact. She's traveled here to have this endoscopic Deuk Laser Disc Repair procedure, which can only be done here in Florida, as we pioneered the technique here. All right, you're going to feel a little stick and burn, okay? I'm going to give her some numbing medicine. You're going to feel a little poke and a little bit of burning under your skin. That's normal. That's perfectly normal for the procedure, okay? You're doing great. Just relax. I like to keep the blood pressure around 100 to 110 systolic. So I'm going to give my anesthesiologist an opportunity to bring it down a little bit. All right, I injected 9 cc's. So thank you for joining us. For those of you who don't know, we broadcast all of our surgeries live from the Deuk Spine Institute. We don't broadcast our interventional pain management surgeries live. There are too many of them, and they happen over 5 minutes, so the broadcast would be extremely short. Pain management procedures, as opposed to surgery, are basically needle-based procedures where the doctor is injecting a medication into or around the spine or using a small probe. It's about the size of a needle to deaden pain nerves so that eliminates pain. We do quite a few, about 3,000 interventional pain management procedures per year here at the Surgery Center in Deuk Spine Institute. And we do sometimes up to 50 a day. So imagine 50 broadcasts in one day. It would be too hard to do. So we really just broadcast our surgeries, and we broadcast all types of surgery, open surgeries, closed surgeries, endoscopic surgeries. But most of the patients that come here, they don't want open surgery. They don't want to avoid the scar tissue. They want to avoid the damage to their spine that comes with open surgery. Many people don't understand that open spine surgery causes damage to the spine. And the reason it does is the surgeons have to go to the spine through what's called the approach, which is usually through the back. And to get to the part of the spine they have to fix, they have to remove part of the spine. So removing part of the spine is never good. Are you comfortable? Removing part of the spine is never good, because when you start removing the spine, you start destabilizing it. And for the last 100 years of spine surgery, spine surgeons just go in and destabilize the spine during their surgery without really thinking much about it, because that's the only way we've been able to do it in the past. But now we have new techniques like the Deuk Laser Disc Repair, where we come in from the side and go through a natural opening that's already in the spine to fix the spine. So by going through that natural opening that's already there, we're not removing any of the natural normal structures of the spine in order to repair it. That's one of the advantages of this technique that we use, is we're going through a hole that's already there to fix the source of pain, which is the tear in the back of the disc. There's no other surgery in the world that does that. We're the only place in the world in 2021 that does the surgery. And we've been doing it now 16 years. So we've been the only place for the last 16 years. Do we have any questions from our audience? Let me know when our blood pressure is down.
None so far.
All right. Are you comfortable? Are you comfortable? All right. I can't really hear. If you could tell me what she's... Yeah, she said yes. All right, good. All right. So, all right, we just need to know if you're comfortable. So she has 3 discs that are causing her symptoms, and my intention is to fix all 3. So we're going to get started. She does have a spondylolisthesis. Let me know if it hurts, okay? Are you feeling any discomfort there? Huh? Let me have that local. You want local? Local. Just giving you some more numbing medicine to make it feel better. Okay? All right. You're doing great. Let's just see where we are. All right, go lateral, please. So we're going to use a special machine to guide me to the source of pain, which is located deep in the spine. As a matter of fact, it's located in a part of the spine called the disc, which is a cushion between bones. Yeah. So, not bad. Not good job there, Jordan. All right. Now this is obviously going to be a challenging one because of the listhesis. She's got that slippage. And when you have a slippage, it's never easy. It's always difficult. So let's hope that things go, well for her. All right, we're going to start with L5S1, Sean. So I'm going to navigate down to that level. Let me know if it's bothering you, Sean. You have 5-1 lined up? Let's line up 5-1. Let's see here. So we need to line up the bones of the spine on the x-ray as well as we can. And that's what Jordan is doing. She has an isthmic spondylolisthesis at L4-5. You can see that the pars interarticularis is elongated at L4. It's very long. All right, let's see what we can do here. We really want to get our x-ray lined up beautifully. That way we can, I think that's probably good. I can feel the arthritis in the facet joints. We just need to get around it. Sean? Sean? All right, let's see. And on the MRI, 5-1 has a decent sized disc. It's not huge. It's only about 80% collapsed. Our pedicles appear to be okay. I'm not happy. We need to be a little bit lower than I am. Blood pressure is good. Yeah, blood pressure is good. You're doing fine. Shot. Yeah, there's only a narrow window here that I can shot, that I can work with. Are you comfortable? So you'll let me know if she has any pain, especially down the leg. Let me, Sean, give me an AP view. So right now, folks, we're actually trying to get down to the part of the spine that's causing her pain. And it's literally an area the size of a pea, a little pea. And I know where it is. That looks good. Let's go back to a lateral. And I'm using the X-ray machine to navigate the tip of this needle to that spot. And that really is what's called the annular tear. The annular tear in the back of the disc on the right side is the source of her pain. All right, that's looking pretty good. Are you comfortable? Yes. Just lay still. You're doing great. All right, so shot. So we're at the back of the disc. What'd she say? A
little bit down the side, but it's okay.
That's the facet. Sean, just relax. She okay? You're doing great. Is she comfortable? Yeah. AP? So we're right there at the back of that disc. And I'm encountering a little bit of bone. She's got some bone spurs, which are not my concern right here because they're not causing any symptoms for her. A lot of people think bone spurs are the cause of pain, but they're not. That's perfect positioning. I think I'm just a little bit higher than the end plate. So we're very close. Very close. Just relax your back and let's try to get a better zoomed in view. She does have scoliosis as well, as for those of you wondering. Her spine is a bit twisted. But again, people get caught up with a lot of the alignment abnormalities, and they get just caught up on that, and they think that those scoliosis or bone spurs. Let's I think we're maybe over-rotated on the orbital plane. Let's just bring it back a little bit and see what happens. Just a little bit, like a degree or two. Shot? Yeah, that's better. All right, we are right there. Literally right there. So we may be hitting the inferior end plate. I thought it was a super end plate. It's really hard to say, but there's a lot of calcification going on here. And I'm wondering if I shouldn't wait till later to try to reposition that. But we're right at the entrance to the disc. It's just collapsed. It's closed down. It's collapsed because she came here with it collapsed. That's what happens when you injure a disc and the injury goes on for a long time, is the disc continues to collapse. And that's another reason to do this surgery early when you have a herniation, rather than waiting for your disc to completely collapse. Get it repaired with the Deuk Laser Disc Repair. And I think that would stop, and it'd be interesting to see. It's a study we need to do, actually. We haven't done it yet, but to compare people who have had the laser surgery and whether it stops the collapsing of their discs. No one in the world has ever looked at that? All right, yeah, I don't know if she's tightening up, but she doesn't feel very tight to me. Not any more than normal, you know. But I'm just not able to access that. Sean, I'm right at the cusp. So I'm okay with that for now. It's not ideal, but it's close enough. And, you know, when she's asleep, we may be able to gain access. So I'm going to make the incision. You're doing great. Don't mind us. So we've numbed up the skin for her earlier. And now we're going to make a tiny 7mm incision. We're going to fix her spine with a 7mm incision, smallest incision in the world to actually do the repair. You're doing great. Now another hard one is going to be L45 and getting in there. And I'm going to try to access it through this incision. But because of the angle, I may have to go further north to get there. So we're just going to have to see. Sean, you're doing really good. Are you lining up 4-5 now? Yeah, I know it's hard. And how do you have her positioned, Louise? She's not on the Jackson table, though. Yeah. Sean? All right. I mean, this is lining up pretty good. So hopefully it'll keep going well for us. Sean? You doing all right? Blood pressure still good? Yes. Beautiful. Sean? All right. So we're about to enter the foramen. We're just passing the facet joints. And I want to skim right along the top of the L4 end plate. That's so I can access that disc. Let's go ahead and do an AP. So far we've lost about 2 drops of blood. So the Deuk Laser Disc Repair surgery we're doing here to fix herniated discs and correct back pain, leg symptoms, is essentially a bloodless surgery. Okay, of course there's a couple of drops of blood we're going to lose, but compared to open back surgery where they lose a lot more blood, it's pretty bloodless. All right, so there's no no transfusions. We've never had to do a blood transfusion. We've never had lateral. We've never had a patient symptomatic from blood loss because you don't lose much blood. So there's no need for hospitalization for this surgery. This is done outpatient at our surgery center here at Duke Spine Institute. We don't go to the hospital for these surgeries. The hospital doesn't have the equipment needed to do the surgeries. The equipment is very expensive, and hospitals just don't budget for it. Sean? All right. So we're right along that end plate. And I know that accessing this disc and the other one may be a little better when we're more asleep. But I want to try to access it now. I'm right there. Sean? I may need to come in a little higher, but I have the right trajectory for my target, but my path to the target is being compromised by some of her natural tissues that are there. Are you comfy? Sean, yeah. Keep running into the top of the L4 vertebral body. So let's see if I can go a little bit higher. Sean? Sean? And by the way, for those of you wondering, this is really the hardest part of the surgery. Sean, accessing the discs. I know it seems counterintuitive, but Sean, once we've accessed the disc, we're fine. The rest of it's pretty easy. Sean, I think that worked. Yeah, but we're directed up, and that's not good. So I'm going to have to change my entry point, perhaps. Try to start a little bit higher. Sean? All right, so why do we broadcast our surgeries live? We want really the world to be able to see how spine surgery can be done and how it could be done safely and effectively if it's done properly. And that you can actually have a good outcome if you have the right procedure done in the right way by the right person. But all those are important variables. I've been doing these surgeries 16 years, and we've been very lucky. We've not had any complications from the surgery. That's good. Sean? Aside from, and not as a complication, but we've had about 1% of our patients re-injure their disc. That's called the reherniation rate. And that's usually due to excessive activity, physical activity after the surgery. Things that they're not supposed to be doing. Shot? All right, so that's a little low. Shot? It looks like we may just have to access this disc from a higher starting point. Shot? Shot? Again, I'm happy with the trajectory, but shot? We're just getting obstructed by her natural anatomy at the area where we're trying to get in, and that's as a result of the amount of arthritis that she has built up in her spine, shot, over the years. So everyone's different when it comes to this arthritis, shot. And we're not here to fix that arthritis. That arthritis is not causing her symptoms of back pain or leg pain, but it's actually just getting in our way. Now that's looking more promising, and I feel the herniation. Shot? Yeah. Yeah. Shot? That's looking more promising, for sure. You okay? All right, they say it's better be lucky than good. It's good to have some luck on your side. So we've accessed, completely accessed the L45. Oh, you know what? Leave it where you were. You can actually see that 5-1 pretty good there. You can see that I'm a little higher than I want to be. I'm going to try to re-access the 5-1 a little bit better. Shot? Uh-huh. And by the way, we're working with sub-millimeter gaps here. Sub-millimeter. Sub-millimeter means obviously less than a millimeter. I think we're in there. Good. Nice job. It takes teamwork to make the dream work. Very good. All right. So far we've lost 3 drops of blood. 3 drops. So really, if you prick your finger, you might lose more. A hangnail, you might lose more. But now we're in. And see, so what gave me the information to access 5-1 was that we just had to change the angle of the fluoro. And Jordan had changed it to get to the 4-5 and show me the path in 4-5, but that also opened up 5-1 for me to see that my needle tip was actually too high. It was banging against the bottom of the L5 endplate. So I've accessed the L5S1 disc base. I've accessed L4-5. You can see the spondylolisthesis at 4-5. So here's for those of you out there wondering spondylolisthesis. So if you go to your spine surgeon, the only time they're going to fuse you, the only time they're going to treat your back pain is when they see a spondylolisthesis. And then they'll do a fusion. Okay? So guess what would happen with this lady? She would get a fusion at L4-5 if she went anywhere else in the world besides Deuk Spine. And if she got that fusion at L4-5, what do you think her results would be? Well, her results would be bad. Why? because they're only taking care of one disc, L4-5. She actually has 3 that are causing her symptoms. But they would ignore the L3-4, they would ignore the 5-1, and that, folks, is the reason why there are so many people that have had spinal surgeries like fusions that don't get better. Okay, not at Deuk Spine, but elsewhere. And the reason is because the surgeons are under-treating the patient. They're only treating a spondylolisthesis. The listhesis isn't the cause of the problem. They're misinformed. And that's why it's actually controversial even to treat a listhesis with fusion. Because the listhesis itself is not the source of pain, and people know that because the results are not good. So a lot of surgeons won't even do a fusion for a listhesis. But what I'm getting at is they're all confused as to what's causing people's pain. But we're not confused here at Deuk Spine. We know it causes the pain. We figured it out. It's just we're waiting for the rest of the world to catch up. And unfortunately, until they do catch up, people are going to continue to suffer because they're going to go to their doctor, and their doctor is going to say, I don't know what's wrong with you. Really don't know, you know. We have no way to fix you. And they won't be fixed, Shot. And it's a real problem. And that's what we're trying to fix with these live streams, Shot. We're trying to help people understand they can be fixed. They don't have to live in pain just because your doctor doesn't know how to fix you, Shot. You can go somewhere where they do, unfortunately. You okay? All right. Everything okay, guys? Good. So I'm up against the facets, and I feel like I'm a little bit too medial. Shot. I'm a little too high there. Shot. So again, it's just a matter of finding the right trajectory. Shot. You're fine. Shot. Oh yeah. Where does she feel that? Where do you feel that, dear? Yeah, well, that's where we are. We're almost done, by the way. We're gonna put you to sleep soon. How'd you like that? What'd she say? Did you sleep good last night? All right. Yeah, you're fine. We're just about to put you out to sleep, and then when you wake up, we'll be done. Where do you feel that? In the back. Yeah, that's what I expect. So we're going through the foramen now at L3-4. This is the last one. In your back, correct? Sean? I can feel the herniation. In your back, right? That I just went through the herniation and the tear. So it's amazing. You can actually feel, I mean, it's not hard, to be honest with you. When you do this a lot, you feel all the structures with your fingers. If you're a skilled surgeon and you know the anatomy, you know where you're going, you can feel yourself pass through the skin, the subcutaneous tissue, the fascia, the muscle. Then you touch the facet, you go anterior around it, and you can feel the herniation in the foramen. And I'll tell you this, I mean, when people get MRIs, they're not laying like this. They're laying the opposite way. They're laying on their back. When you're laying on your back, the herniation is not going to be as prominent, it's not going to be as big or full. When you lay on your belly in extension, you're going to have a bigger herniation. So I can actually feel the herniation in the foramen with the tip of the needle, and you can look at the x-ray and you can actually see where it is. It's usually out further than you see it on the MRI. On the MRI, remember, they're just not loading their disc, whereas here they're loading the back of the disc because they're in extension. All right, we are pretty much done accessing the disc. We had some good luck. Okay, so now you came here with a lot of back pain, right? How long have you had that back pain? When did it start? When did your back pain first start in your life? When did you first get back pain? I can't really hear her. So prior to a year ago, you never had back pain?
Not much.
Yeah, but you had some, right? It got worse a year ago. When did it first start? The first time you ever had pain in your life in your back, when it started?
Still a year ago.
A year ago, all right. So everybody's story is a little different. For her, she started about a year ago having severe back pain, and it didn't go away. She tried everything that everyone else tries, herbal, medications, pills, you know, therapy, exercise, I'm sure. But basically, none of those things are going to take it away. There's actually nothing in the world that will take the pain away except this surgery. Why? Because there's a little tear in the back of her discs, 3 of them, and through that tear, it's called the annular tear, she has the jelly in the center of her disc has actually bulged through the tear, okay? And that's what's causing her pain. And there's no medicine that fixes that. There's no shots that fix that. It's literally the Deuk Laser Disc Repair is the first surgery ever to figure this out and address it. And we're going to fix it endoscopically. So this is the L34 disc. L34 now. I'm just drawing on the back of her skin here. It's not on her skin, but on the covering over her skin. And we're using a surgical marker just to tell you where things are. And she's going to get a copy of this video. She's going to watch it, and she's going to want to watch it and see what happened in surgery. All of our patients do. So we're going to test these discs to see if they're causing her typical pain. What did she say? She comfortable? Are you comfy? All right. Okay, did you see that response? I think everyone saw. How bad was that pain on a scale of 1 to 10? How high did it go up? It didn't go any higher than an 8? 9? Is that where you typically get back pain? All right, folks. You can see on the discogram, the x-ray that we just took, that we filled her disc with some special dye. The dye itself, if I were to put it into your back and you don't have any back pain, you wouldn't feel it. You wouldn't even know it's there. But because she has a inflamed tear in the back of the L5S1 disc, because she has that inflammation going on, it's kind of like having a zit on your face. If you take your finger and put a little pressure on it, it hurts. You feel a sharp pain. So anytime you push on inflamed tissue, you're going to get pain. And so it's highly localized pain. Localized pain means you can feel exactly where it's coming from. And she could feel it in her lower back. And that's her typical pain, so it's concordant. That was L5S1. That was a 9/10. That's how high it got. We always record the highest it goes. And the way she jumped on the table, I knew it wasn't just an 8. I knew it was higher. Hey, great news. When you wake up, that pain will be gone for the rest of your life. Isn't that great? That's why you flew all the way here to the United States. How bad is that on a scale of 1 to 10? 10? All right, that was the L45, folks. Look at that tear. Look at the leakage of the dye through the tear in the back. It's huge. That was she said a 10. Is that your typical pain? Is that where you get back pain? Yes. I love her answers. She's so direct. Thank you. You're a great patient, by the way. And your surgery is going perfectly well. Everything's good, okay? Can you hear me? All right. How many discs did we test? What'd she say? How many did we test so far? How many discs have we tested so far? We tested 2. How bad is that on a scale of 1 to 10? 10. All right, well, we tested all 3 now. Guess what? You get to go to sleep. Is that where your pain typically is? 3 discs. I predicted all 3. Okay, based on how did I know this? So the L5S1 was a 9 out of 10, L45 was a 10/10, and L34 was a 10/10. Okay? Basically what we've established here in the operating room during the Deuk Laser Disc Repair, We do a discogram. It's called an evocative discogram. It's part of the surgery. And we just tested these 3 discs that I thought, based on my 26 years of experience as a neurosurgeon, I thought these 3 discs are the cause of her pain. And that's based on the MRI review that we have for free, by the way, online. Anyone that wants a free MRI review, we do it. And I do it personally. Luis and I work together with our team, and Sean, who's leaving us to go work for a bank, who's going to steal people's money. Sean and I and Luis do this, but I have a feeling Sean will be back. I have a feeling he'll be back. That's my gut feeling. That's my discogram feeling. So, based on our physical exam in the office yesterday, when she flew down from Canada, she came in. I mean, we did this with Skype too. I kind of knew it was these 3 based on our Skype and our MRI review, but I confirmed it on the exam. And we just confirmed it now in the operating room, 100%. 100% we've proven those 3 discs are the cause of her pain. The only thing I've done is test the discs. We didn't test muscles, we didn't test joints, we tested the disc. And we're going to fix these 3 discs right now with a laser, and when she wakes up, that pain will be gone. She will not be on any pain pills. She'll literally, she's getting propofol to put her to sleep. It's not a pain medication, it's just a sleeping aid. And when she wakes up, that pain will be gone. All right, so let's just hope everything else goes well. Here we go. We're going to get started. Are you asleep? Yes. All right, she's asleep. So we're going to start at 5-1. Guide wire goes in. Shot. Okay, I'm going to leave the guide wire in. Shot. And I'm going to remove this needle. Why are we showing you this surgery? Because we want the world to know back pain and neck pain can be cured. Today, in 2021, and we've been curing back pain at Duke Spine Institute now for how many years? Since 2004. Okay? So don't believe your doctors, don't believe what you hear in the press or the media, don't believe your insurance company. Your pain can be cured. You just have to find the right doctor to do it. You don't have to live the rest of your life in pain, avoiding things. Be normal. Shot? All right. Here we go. I'm going to bring the dilator down. She seems to be very comfortable. She's not responding with pain. The dilator is basically shot a metal pencil, and it's not really a pencil, but it looks like a long pencil, and it just slides down this guide wire. And really the amazing thing about it is that it doesn't damage any tissues. The only damage in this entire surgery is that cut right there, 7 millimeters. But we're actually spreading apart the fibers of the fascia and the muscle to get to the foramen. And now we're passing through the foramen. There's really nothing in the foramen except for a nerve, root, and the arteries and veins that feed the spine. So we're actually making our way past the nerve root. We're actually below it, for those of you who really want to know. And we're going just below that nerve root. And we're going through an area called Cambin, K-A-M-B-I-N-S, Cambin's Triangle. And Cambin was the first pioneer in the world to really understand the anatomy of the neuroforamen. And Cambin is an orthopedic surgeon. I don't even know if he's alive anymore, but he was the first person to use this access technique to go from the outside world to the disc. Is that current? Shot. So I'm not ready to take this guide wire completely out, but I want to back it out a little bit. Perfect. And the fact that she's asleep now makes my job much easier because she's not clamping down on that back of the disc from pain, because she's not feeling pain. She's not perceiving pain. What is the perception of pain? perception of pain is quite interesting. Pain is truly just how your brain interprets electrical signals, specifically signals that are transmitted to a part of the brain called the primary somatosensory cortex, which is a thin strip of brain that's located in the parietal lobe, for those brain buffs out there. And it's the first gyrus, the foremost gyrus in the front of the parietal lobe. And it's called the primary somatosensory cortex, with Brodmann numbers 312. Brodmann is a neuroanatomist who sliced up human brains after they died, of course, many years ago, and assigned numbers to areas of the cortex of the brain, which is the outer surface of the brain, in order to define what he saw with a microscope. And he described the cytoarchitecture of the cortex, which is basically the structure of neurons and supporting microglia cells, and how they look different in different areas. But, you know, there's an old saying, structure begets function. So he started by looking at the structure, but didn't understand the function. It wasn't until many years later that we started to understand the function of these areas of the brain. And of course, the primary somatosensory cortex was where all the pathways, all the nerves, that should be good, that travel from sensory areas of your body end up in that part of your brain. And those impulses or electrical signals create a perceived or basically a perception of the environment. Okay? So when you look at people around you, your brain automatically recognizes the people that you're familiar with because their visual image, their shape, their color, their shadowing, all that information travels from your eyes directly back to your occipital lobe of your brain, and then it goes to association areas of the brain on the side of the primary occipital cortex, which is along the calcar sulcus, and you then give meaning to those shapes, right? So if you're standing out in a field and a shape approaches you, you're going to want to know if that shape approaching you is your friend, or if it's a raging bull with his horns tilted down towards you. Because if it's the bull, you want to get the heck out of the way, right? But you're not going to know that unless your brain associates that shape and image with something dangerous, like a bull. The reason I chose a bull is I was watching the Formula One race last night from last weekend at the Red Bull Ring, and they have a giant bull, and I'm hoping someday my son will be able to race there for the Red Bull team. He's on his way. All right, so let's get started. We are now in the L5S1 disc, and look at that. Lo and behold, what have I found? Huh? What am I seeing? The same thing I've seen 3,000 times. It doesn't matter how old you are. It doesn't matter what color your skin is. It doesn't matter how intelligent you are. Nothing matters. It's always the same. It is a tear with herniated material stuck inside the tear. And that is what the Deuk Laser Disc Repair fixes. And that's how we cure pain. And unfortunately, we're the only place in the world that does this at this time. That's good and bad. It sucks to be a pioneer, but we are pioneers. And unfortunately, pioneers are rarely appreciated for what they do. And then everyone steals their ideas. So I'm still waiting for everyone to steal the ideas that we created here at Deuk Spine, but that's because most surgeons don't even know about the surgery. They don't even know it exists, let alone how to do it. You know? How can you make ice cream if you don't even know ice cream exists? Think about that. That's the situation right now in 2021. is most spine surgeons, and when I say most, I mean 99.999% of them worldwide, have no idea this technology even exists. It's like asking a child in, okay, here's where I'm going to get in trouble. Let's just say a child in the deserts of, living in the deserts of Saudi Arabia. What does ice cream taste like? What does it look like? They have no clue. They don't even know what ice cream is. They've never seen it before. There is no ice cream in the desert. Let's just say, you know, go back to 50 years ago, there was no ice cream in the desert. So they wouldn't even know it exists. They have no concept of what it is. And that's unfortunately where we are with this technology that you're watching, the Deuk Laser Disc Repair. And yet it's significant. It's not like ice cream, which just makes you feel good for a little while. But this actually cures pain in the neck and back. This is the only surgery that cures pain in the neck and back. It can also cure arm and leg pain if you have arm pain and leg pain from a herniated disc. So there's the tear. That's what we're here to fix. There's a piece of herniation. And my point is, with this is reproducible. This is the same thing over and over again. You know, it's kind of like human beings were all born with 2 arms and 2 legs, right? The structural anatomy is very same. We got a face, we got 2 eyes, we got 2 ears. These disc injuries are all the same. They all look the same because they're all the same. You know, there's a tear and then there's herniated material. How much disc is left in the space? Who cares? It has no bearing on on the pain this patient's having. Whether there's listhesis, scoliosis, kyphosis, none of it matters. And yet that's what all these other spine surgeons look at. And they look at these deformities. And I don't mean all of them, I mean the good ones. Unfortunately, the good ones are still so far behind in their understanding. Why am I taking so much time to talk about the lack of understanding of spine surgeons? Because that's where people with chronic back and neck pain, many of them end up seeing spine surgeons. And their spine surgeons don't have answers for them. Their primary care doctors don't have answers. The chiropractors don't have answers. The physical therapists don't have answers. All they want to do is give you pills, pain meds, because that's all they know how to do. And yet those pain meds have created a generation, going on 2, of drug addicts, basically. In Florida alone, every day there are 7 people that die every day from prescription narcotics. And that's an old figure. I don't even know if it's higher now. 7 normal people, regular people. We're not talking about this salivating, sweaty people on the street that are drug addicts. We're talking about your co-workers, your family members, your children, your parents, people like that that die every day from drug overdose of prescription narcotic drugs for pain. Rather than fixing the problem, they're just taking pills. And it's not the patient's fault because they don't know any better. They're trusting their doctors to give them the answer, and the doctors are failing them by giving them pills. And that's why we want to fix that. We want you to see, as patients, that your problem can be cured and eliminated. You just have to go to the right place to do it. All right, see that little pink thing right there? That is a nest of granulation tissue. That is a nest of inflammation. That's like a ripe, red, swollen zit. And it's like a little pressure spot, a pain generator. So we're going to have to do our best to zap it away inside the tear. You can see the tear. There's more of it there. It's all pink. This is all scar tissue within the tear from chronic inflammation. Now, some people who are smart may say, how do you get inflammation inside a disc? There's no blood supply. Well, normally, in a normal disc, there's no blood supply in the inside of a disc. But in a damaged disc with a tear, you do get blood supply because you get chronic inflammation. And that chronic inflammation brings with it blood vessels. A lot of people don't know that. We call it neo for new vascularization, neovascularization, and we call it neo for new neurulation. Neurulation means a new nerve network of pain fibers, usually. And guess where those nerves come from? They come from the sinovertebral nerve, which is located in the foramen, and it is a somatic afferent nerve fiber. It carries somatic afferent fibers. And somatic afferent fibers project up to the brain, specifically to the primary somatosensory cortex of the brain. So patients actually feel exactly where the pain is coming from, the inflammation, because of the type of fibers going to the brain. Unfortunately, most doctors don't know all this stuff because we've pretty much put it together right here at Deuk Spine. All right, you can see I'm doing what's called a debridement using a laser. For those of you who don't know, the blue thing is the laser. And it has a little clear tip. That's the actual, that's where the laser energy is being emitted. And some people say, well, I don't see the laser firing. That's because it's invisible to your eyes. Laser energy is generally invisible to your eyes. And people will say, well, I've seen red lasers and green lasers. Yeah, that's right. Huh?
In Star Wars?
In Star Wars. No, but I mean, people buy lasers online. They're tactical lasers and things like that, and they have a light source that's visible that goes with it. That light source just is to illuminate for you to see where the laser is actually directed. But this laser energy that we use here for this procedure comes from what's called a holmium YAG laser. It's a medical grade laser. And this holmium YAG laser is, it's not a cheap laser you buy online. There's a piece of herniation, by the way. I'm going to go grab it. Laser off. The holmium YAG laser runs about $100,000 for the machine. Look at that piece of herniation. So how did that herniation get inside the disc? Well, remember, I shoved it in a little while ago when I entered through the tear that was already there. I pushed the herniated fragments into the disc. So,
we have some questions.
Yeah, we'll take the questions. Go ahead.
Our first one comes from a viewer on Facebook.
You need to speak louder. I can't hear you.
How's this?
That's better. Could be better though. Maybe 5% more. Go ahead.
Okay. The viewer on Facebook is wondering, are MRIs always done with the patient laying on their back?
I heard with the patient laying on their back, but I missed the very beginning.
Are MRIs always done on the back?
Are MRIs always done with the patient laying on their back? The answer is no. 99% of them are, but that's because most MRIs don't allow the patient to sit or stand. However, there are now standing and sitting MRIs that are being sold, manufactured and sold and used. And they've been around for a while now. They've not been very popular, but they're more useful for spinal issues. But in the end, folks, it's not the MRI that's limiting, it's the doctor that's limiting. It's understanding the MRI. The MRI that this patient has does show a smaller herniation, but just understanding that it's not the size of the herniation that matters, it's whether the herniation is metabolically, inflammatorily active. And that an MRI never tells you. I mean, you can sometimes see hints of it with what's called bright areas or high intensity zones, HIZs, but it's not reliable to look for HIZs. If you just look for HIZs in the back of a disc, you're going to miss 95% of people with a painful disc. So it's really just about it's putting together the physical exam with the patient localizing their pain using their finger, combined with a annular tear, small herniation on the MRI. You have to have what's called a high index of suspicion to the source of the pain being the disc. You have to know the disc is the source of the pain. So the problem is that doctors don't believe discs cause pain. And that's why I spent so much time talking to you all about the pathway of pain from a disc to the brain, and that they do cause pain when they're damaged and inflamed. But if you ask most neurosurgeons, can a herniated disc cause back pain, they're going to say no. No, they don't. Or neck pain, no. They don't cause back pain, they don't cause neck pain. If you go to that surgeon and say, hey, I got a herniated disc, with just back pain. They're going to tell you to get lost. They're going to say there's nothing I can do to help you, okay? If you go to your surgeon and say, I've got a herniated disc with back pain and leg pain, sciatica, they're going to say, okay, let's operate. But if you ask them, what can I expect after my surgery? Will my back pain go away? They're going to say no. Will my back pain get better? 50-50 chance that it'll get better. But it won't go away. Why? Because they're not operating on you to get rid of your back pain. They're operating on you to get rid of your leg pain. So, yes, a laminectomy, microdiscectomy, many times can be successful at eliminating neck pain or arm pain, if it's in your neck, but they don't treat back pain, and they don't treat neck pain. So you got to distinguish back pain, neck pain versus arm and leg pain. Spine surgeons treat arm and leg symptoms. They don't treat back pain with surgery. We do, because we are treating something they're not treating, because they don't know to treat this thing. There's actually a bone spur. For those of you wanting to see a bone spur, right there, you can actually see it's pretty well developed bone spur. It's got trabecular bone in it. Remember I had trouble getting into the disc earlier? That's because this area has some bone spur. The yellow stuff at the top is fat, by the way, in case you're wondering. And we're not trying to get rid of the fat, but it's getting in the way, and it's getting rid of it's not going to hurt the patient. So I am getting rid of a little bit of fat. We don't charge extra for that.
We have another question.
Sure.
A viewer is wondering, Dr. Deuk, how many years did it take you to learn this technique?
How many years did it take you to learn the technique? Great question. So let's break the technique down into two parts, all right? The part that I learned from other doctors and the part that I had to do on my own. So the part that I learned from other doctors was the skin incision and the needle and the tube and the scope and getting into the foramen where the herniation is, okay? Getting into the actual foramen and into the herniation. But the part about fixing the annular tear, that I developed. And I was doing it in the beginning because I was using a laser. And believe it or not, a lot of doctors, they laugh at using the laser in spine surgery. They don't understand the laser is essential to fixing the pain. So they just use the grabbers. And so I was pretty much started using the laser on my own. All the other doctors that taught me were using the what's called the bipolar. And I don't use the bipolar. And it's complicated, but the reason they were using the bipolar is because they made a lot of money every time I used their bipolar. In other words, it's a disposable item. It costs $500 every time you do surgery. And I didn't think it worked very well. The laser is far better. So I started using the laser after I saw somebody use a laser, and they used it as a one-off, but I saw the value of the laser and I started using the laser myself. And the results were amazing with the laser on the tear, which they weren't using it on the tear. So it's a complicated answer because the history is a little complicated. All right, what is that? Is that the fat? Yeah. Just about done with this disc. So it took me, believe it or not, I went overseas to learn how to do the basics of the technique. Laser off. And scope off. Wait, actually, let's suck it down. The basics of the technique I learned in a few days from watching the world's best endoscopic surgeons at the time. And they were South Korean and German and American. So I was trained by many of them. And the training I got occurred over like weekends where I would travel to learn this type of surgery, okay? I would travel. And I would travel overseas, or I would travel in the United States to go and spend time with these surgeons. So it didn't happen in one episode. It took many episodes of traveling and building on the basic principles of endoscopic spine surgery. The cervical spine, the stuff I do in the neck, I learned strictly from the South Koreans. Dr. Seng-Ho Lee, Dr. Gun Choi, they were my teachers, and I had to go overseas and learn from them. And I learned really in 3 days. But for the lower back, there was other doctors that did it, like Dr. Anthony Young, and I spent a fair amount of time training with Dr. Young, Anthony Young, out of Phoenix. He's retired now. So for the Koreans do it very different than I do it. I had to basically refine the technique over several, probably over the first 50 surgeries I did. I refined the technique. I made changes, little changes to the technique to make it better, safer, more effective. And so, you know, it was a process. It was a process of modifying the technique, and it probably did that over at least a year or two, the first 2 years. Remember, I've been doing this surgery now going on 16 years. So for the first 2 years of doing these surgeries on my own patients, I modified my technique to make it better. And really, it's been pretty stable now for like the last 10 years, where I haven't really modified my technique very much. If you watch my videos, you'll see that the actual surgery I do is pretty much the same every time. That's because I've already tried many different ways of doing it, and I keep coming back to close to quote-unquote perfection of the technique as possible right now and for the last 10 years. Okay? I hope that answers the question. Alrighty, we're going to start the next disc, hopefully. What's going on, folks? We lost our feed. What's the next question? Louis, some pressure.
Give us just one moment. We are working on some issues with the camera at the moment.
Luis. Sure, you didn't touch anything. That's what they all say. You have any questions?
Yes, we do have a follow-up question.
All right, go ahead. Let's take the follow-up question first, and then I'm going to take one from our good anesthesiologist.
Okay. The viewer from YouTube is wondering, Dr. Deuk, does the disc repair change the anatomy of the disc at all and cause a change in stability?
Yeah, great question. So, does the disc repair change the anatomy of the disc at all? And the last part, I'm so sorry, I was thinking about the first part answer. And does it what?
Change the stability, yes.
Yeah, all right, good question. All right. Imagine someone takes a knife and slices your arm down to the muscle, down to the bone. Let's just call it a deep cut. And you leave it alone, hoping that it will heal on its own. But it doesn't heal on its own. It starts to get red and swollen and really painful. Okay, that's how people come to me with their disc injuries. Are we back online? Yeah. And I take that wound that's not normal and I clean it up surgically, debride it, and sew it back together basically, and then it heals, and all there is left is a little scar. But they restore their function, they restore their movement, they restore everything. It's back to perfectly, quote-unquote, normal. That's what we do with the surgery. I'm trying to make an analogy to help you understand. The things that we're removing with the laser are not normal. That is inflammatory tissue. It is grunge. It's not part of a normal disc. It's created by your body's response to the injury to the disc, to the tear, and the nuclear material stuck in there. So all that stuff I remove is abnormal. It shouldn't be there. It's not part of a normal disc. It came as a result of the injury and the inflammatory process that has ensued. All right, so are we good here? We're starting L45 shot. Let's see where we are. I've got to get the guide wire down far enough so I can take the needle out. So you got to be careful doing this. You don't want to go too far with the guide wire. There it is. So otherwise you'll end up poking the belly with the guide wire or poking on the intestines or blood vessels, it could be bad. Shot? So you want to watch the tip of the guide wire. It's in the front of the L45 disc, and not let it pull out or go forward as you do this. Okay? Shot. So I want to gradually, and we're fine where it is. There's no problem. I'm going to gradually remove the needle, shot, without pulling out the guide wire. Almost there. And this is that listhesis level, the level with the spondylolisthesis. Okay, I hope I answered the question. And as far as stability goes, the surgery that we're doing actually improves the stability of the spine. Okay, there's no other surgery except for fusion that's going to improve the stability, but when you fuse, you lose movement altogether. So yeah, you're stable, but you have no movement. So fusion, in terms of correcting stability, I think in the future, once everyone learns this technology, fusion will only be used for like serious fractures or tumor surgery where you're removing large parts of the spine and you've got to fuse in those cases. But to repair discs, painful discs, fusion should never be used, in my opinion. Okay, I've taken on every kind of disc injury you can imagine, from every stage of degeneration, from little herniations and annular tears to total dehydration of the disc, total collapse of the disc. And I don't fuse it, I don't reconstruct it, I don't put anything unnatural. I literally go in and find the tear and repair the tear by debriding it. That's all I do. And by doing that, we take the pain away. So what does that tell you? It tells you there's no stability issue, okay? It's actually, everything comes from that tear that I'm debriding. Our anesthesiologist had a question for me.
Yeah, I'm wondering, you have a little pinhole with the pencil you're looking for, and the surface area of the tear, or what is the surface area of the disc you're treating? Are you able to see the whole surface area with your view?
Am I able to see the whole surface area of the disc with my view? No. No. We use basically the physical exam where the patient's pain is it more to the right or left? And then we look at the MRI and we look for the tear. If the patient's pain is at L45 to the right, we look at the L45 disc on the MRI and look on the right side. Is there a tear on the right with a herniation? If it is, then we go to the right side at L45. So all those decisions are made preoperatively, before surgery. We don't change the surgical plan during surgery. I've never had to do that. I mean, unless I couldn't get access to the disc, then I had to abort. But we don't start adding things or look around. It's basically, we're going right through that tear. So right now where the tip of the dilator is, I'm literally right behind the tear. And I'm about to go through the tear itself. So to repair the tear, you have to go through the tear. Is it possible to miss parts of the tear? Yes, but I have a good visualization of that whole area with the endoscope. And the way you're going to miss parts of the tear is if you're kind of like in the beginning when I first started learning the technique, I didn't understand what, the lateral part of the tear, the backside, and now I always look back there. So yeah, I'll show it to you. But when I'm working normally at 12 o'clock is the medial side of the tear. At 6 o'clock is the lateral side of the tear. So you always want to check lateral. It took me a while to understand that. I didn't have that knowledge right away. Dr. Young taught that to me. So the reason I'm advancing the dilator right now with the guide wire still there is that if you don't, you're going to get in trouble because your dilator is going to end up going somewhere it shouldn't go. And I have been in here enough times, Sean. I've been in here enough times to know that I have to force this dilator north in order to get the tip pointed south. And that's what I'm trying to gently do. You don't want to have an issue with the guide wire. That would just suck. Is it possible? Yes. you hope to God it never happens. So right now you can see the disc is opening with the dilator, okay? Starting to spread open. All right, so now I'm going to remove this guide wire because I don't want to snap it or break it or trap it. Trapping a guide wire can cause it to fracture. And then you're going to have a retained foreign body, which is not the end of the world because it's all sterile, but you don't want that. Sean? So this is that listhesis level, remember. This is the level where the bone is slipping forward on the other bone. It's almost a grade 2, almost at 50%. Any other surgeon would freak out and want to fuse this, but we're not going to fuse it. And I've done so many of these listheses now over the years, and every one of them does so well, and we don't fuse them. Now, could I fuse it? Sure. We could be doing a fusion. But if I were going to fuse this patient's spine, I would fuse 3, 4, 4, 5, 5, 1. I would do all 3 levels. Because if you only do the listhesis level, which is what every surgeon in the world will do, is just the listhesis level L4, 5, their patient will still have pain at 3, 4, and 5, 1, right? Because we tested those discs and we saw they still have pain. So that's the problem with conventional spine surgeons and surgery, is that lack of understanding of the source of back pain. And that's what we're trying to rectify with these broadcasts and this educational sessions I do for the public, is I'm trying to get the public to understand that modern medicine doesn't understand where back pain comes from or neck pain comes from. They're just kind of guessing. And because of that, they can't fix it. That's why there's so many people with pain walking around. But Deuk Spine can. Many times it's because it's undertreated, meaning the surgeon only fixes one level when they should be doing 2 or 3. So you want to know an interesting fact? The average patient with back pain from a herniated disc, the pain is coming from 2.5 discs, 2.5 discs. So what does that tell you? If pretty much every spine surgeon out there just does surgery on 1 disc at a time, what does that mean? It means that most patients are going to continue to have back pain after their surgery because the surgeon isn't treating all the discs. And of course the technique they're using is not right either. All right, any other questions?
We do have one.
Whoa, Betsy.
A viewer from YouTube, it says, Dr. Deuk, I'm having sharp pain in my back around my ribs when I'm in any certain position, like a knife being stuck in me. What could this pain be from?
All right, good question. So we have a viewer who has sharp pain in their back and ribs, and they want to know what could be causing it. So here we're dealing with a situation where we don't have any MRI, and we just have a complaint from a patient. So we need to create what's called a differential diagnosis, right? Differential diagnosis is doctor's way of listing all the possible causes. Imagine if you go out to your garden and your favorite flower is dying. Well, why is it dying? Okay? And there's a list of causes, right? And those causes could be too much fertilizer, it could be not enough sunlight, too much water. There's a list of causes, and you got to start going through those causes and eliminating them. So it's no different when we deal with people with back pain, like this person who's asking us. So we create a differential diagnosis or a list of possible causes, and we start to rule it out. So one cause could be a fractured bone, which you could find on an x-ray. Another cause would be a tumor or an infection, which could be found on an MRI scan. Another cause could be, there's a piece of herniation there. Standby laser. Another cause could be the herniated disc, like we're dealing with here. Another cause could be facet pain. That means pain from the facet joints. Okay, there's a piece of herniation. Nice little chunk. You know, there could be other causes that are more obscure, like blood vessel issues, say an an aneurysm of the aorta. So we like to categorize causes in medicine into general categories. And for the spine issues, it's degenerative causes like disc problems, facet problems. It's tumor. So it could be a cancer spread to your spine. It could be primary tumors of the spine. There's lots and lots of those. Could be, hold on a second. Let me just see what this is, if that's a loose fragment or not. And it could be infectious. So there's a lot of infectious causes. Okay, I was just reading in the news, as a matter of fact, that one of the companies that make bone graft that's used for spinal fusions. This is not a spinal fusion, by the way. This is the better alternative than a fusion. But lots of surgeons do fusions these days, and one of the bone graft companies now has 91 cases of tuberculosis in the spine of patients who had fusions using their bone graft, using their biological material. We don't use biological material in this surgery. That's, we don't need any bone graft, we don't need any metal. And that's one of the reasons why basically it's Deuk Spine versus the entire spine world, is that the spine world is controlled by companies that manufacture and sell metal to fuse your spine and bone graft to fuse your spine. And here's one of those companies that has 100 cases of spinal tuberculosis proven to come from their product. So how did that happen? Well, they clearly took the bone graft from a patient with tuberculosis. And what's more disturbing than that, so they're supposed to screen their bone graft sources and make sure the patients don't have any infectious diseases. But what's even more disturbing is that they didn't sterilize it properly. Holy God, this is two giant mistakes that should never be made. That is way below the standard care. Point is, folks, you don't want bone graft in your body. You don't want a fusion. You don't want artificial disc. This surgery is all natural. We're not putting anything in the body. There is no bone graft to cause tuberculosis like what's happening right now. This is a story in the news this last week, by the way. Look it up. Google it. That's why this all-natural surgery is not popular, is because companies are going to lose a lot of money because we're not putting any bone graft in people. And they don't want this surgery to become popular. That's why I go straight to you, the consumer. Because if I was a patient, I would want to know the truth. And I would want the safest, best surgery to get rid of my back pain. And this is it. Have I put bone graft in people? Of course I have. I've been a neurosurgeon 26 years. I learned all the old techniques before I learned this new stuff. So I was doing all that. I still do it. Some patients, they don't want the laser surgery. They want a fusion for whatever reason, or their insurance won't pay for it. So they have a fusion instead. It's sad. But, yeah, I still put bone graft. We've fortunately never had a problem like that with the company that I use. But it just highlights the fact that when you start putting unnatural things in people's bodies, it can cause very bad reactions. All right, take that for a second. We got a little bit of herniation that's giving me a fit. I think I might have floated it out or cannonballed it out. All right, any other questions?
Yes, I have a question.
Oh, we have a question from the operating room.
Will any of this material grow back?
Will any of the disc material grow back? The answer is no. The only part of the disc that will grow back is the tear that I'm cleaning. That will grow back. But the actual jelly in the center, the nucleus pulposus, that you're born with a fixed amount and you never get more. You can't more. And honestly, you don't need more. Everybody obsesses over, oh my gosh, I lost some of my disc. That's it. No, you really don't need it. There are so many people, like literally tens of millions of people with no jelly left, and they walk around with no symptoms, no pain, and they live a normal life. You know what I mean? So there's no need for it. The problem is people have tried replacing the jelly with synthetic jellies in the past, and what always happens is the synthetic jelly squeezes out through pressure. And then guess where it squeezes out to? Right on their nerve. So they come in with like weakness in their leg, a drop foot. So none of these products have ever been approved by the FDA because they're not safe. They've never gotten past the testing needed, the 3 levels of testing needed to become FDA approved, because they fail at the most basic level. They just fail. And I'm telling you, knowing everything I know, you know, I used to be a big like, oh my gosh, we got to find something to replace the jelly with. That was in my ignorant years, you know. But now I realize we don't. And maybe I'll change my opinion when I'm older. Who knows? Maybe there'll be some new information. But right now I can tell you, you don't need to put the jelly back in your disc. We've talked about this before, but what is that jelly? It's an embryological remnant of the notochord. Notochord is a tissue that induces other tissues in a young, early embryo to form the 3 germ layers, the 3 primary germ layers. Those germ layers are endoderm, mesoderm, and ectoderm. And those germ layers become a human being's skin. That's the ectoderm. Lining of the gut, part of the ectoderm, at least in the beginning. And then all the organs, skeletal muscle, skeleton, it's a mesoderm. And then the endoderm becomes like the lining of the gut and the respiratory tree, you know? So the notochord, once it's done orchestrating all that, it just kind of breaks up into little balls and makes up the center of discs. I've always been amazed that probably the most important and most powerful tissue in the human body, the notochord, becomes the nucleus pulposus, which then can be creator of problems later in life when it leaks out. And again, this was discovered here at Deuk Spine Institute, the part about it causes problems by creating inflammation through annular tears. All right, what other questions do we have? We're almost done at 4-5. You can see the end plate here. That's the end plate or bone above the disc. That's the L4. And then the other bone below is here, L5. And I'm working in the disc between them. This is the L45 disc. Just about done.
We have another question.
Sure.
A viewer is wondering, do you fix neck issues the same way as you fix lower back issues?
Okay, great question. The answer is yes. For neck pain, we also fix neck pain, just like we fix back pain. We use the Deuk Laser Disc Repair, the same surgery you're watching now, except we use a skinnier tube and a skinnier endoscope, and we go through the front of the neck, not the back. So the front is the right way to do it, and that's what we do, and it works just as well. Our average pain relief is 98% for our patients that have this surgery, whether they have it on their neck or their back for neck pain or back pain. We've also started doing thoracic herniations. We've done 9 of them, I think 9 or 10 now, and all of our patients have done exceptionally well. There's been no complications. So you can have the laser surgery done for a thoracic herniation as well. Basically, any spine pain you have, we can take care of. We just really don't do tumors and infections. But tumors and infections are rarely the cause of people's pain. They're not common. All right, just about done with this particular disc. And by the way, for the people that are asking, if you want to go see the surgery done on the cervical spine or thoracic spine, it's available for free. We've done it in the past. We have it all recorded on our app, the Deuk Spine Institute app. I would recommend you download the app. It looks like we're running low on irrigation. Did you pump it up? Yes. Is this a new bag? Yes, all right, yeah, it's important to keep up with that. There go the bubbles. So this is the last of the herniation and tear debridement right here that I'm getting. But if you go to the Deuk Spine Institute app, download it onto your phone. It's free. We don't charge for it. And in that app, there are resources where you can actually watch the entire surgery done on someone's neck for a herniated disc in the neck, or on their thoracic or their back. We have literally hundreds and hundreds of surgeries on YouTube. We probably have close to 1,000 surgeries on YouTube, full surgeries now, including fusions if you want to watch it. Whoa, look at that herniation. If you want to watch a fusion surgery. That was pretty cool how that little piece of herniation just slid out of that annular tear there. All right, any other questions? I'm actually behind the L4 vertebral body right now, getting a piece of herniation out from behind the vertebral body, just under the pedicle. And this is all posterior ligament right there. It's all grungy because of all the chronic inflammation.
We do have a question.
All right, yes.
Viewer from YouTube is wondering, what is the temperature of the saline irrigation that you're using?
That's a great question. What is the temperature of our irrigation? It's refrigerated. So it's probably 8 degrees. It's cold. We use cold irrigation to keep the laser cool and the tissues cool. All right, we're done here. Take that. Let me have the grabber. I'm going to get that piece of herniation out. Yep, we use cold irrigation, just refrigerated. And you can use saline or lactated ringers, either one. But normal saline, you know, it's really weird because somehow these companies that supply us, sometimes they tell us that they have no more saline, and they want to raise the price 5-fold. Hey, our suction's not working. There we go. Thank you. Yep. Scope off. All right, so that is 2 discs. We got 1 more to go. The last disc we're going to do is the L34. Would you, my lead is falling off my hips. I went to Maine and I biked for 3 days, and I think I might have lost ½ an inch on my waist. If you can just grab it and pull it up on the sides, I would appreciate it. Yeah, that's perfect. Thank you. My booty is getting smaller. Okay. Yeah, let's get this tube out. By the way, we were able to do all 3 disc repairs from 1 little incision, 7 millimeters. Literally the size of half of a US dime. And I'm not talking about drug here. I'm talking about like a monetary unit, a metal dime. All right. Okay, come on in with the fluoro. So we're going to bring our fluoroscope back in to help guide me get the tube in the right spot. For the last disc, this is the top disc, the L34. And then Dr. Patel, we need to notify him. Yeah. All right, well, we just got probably 10 more minutes to go. We're on our last disc. Okay, let's bring that north a little bit. And there's a fluoro all the way to the ground. I think your orbit is wrong. There you go. Let's rotate a little bit more. You're about a degree off. So rotate us a degree. So she has scoliosis, so the bone, yeah, that's perfect. The bone that, if you look at the wire, the needle and the wire that are inside the next disc, look at the bone above, which is the rectangle above. It was a little bit rotated compared to where we were. So that's because of her scoliosis. So we are actually repairing the disc, not the scoliosis. I get patients sometimes after the surgery, they say, hey, you know, my MRI shows that there's still a bulging disc or herniated disc. Yeah, we're not making your disc look normal. We're getting rid of the source of pain. So we're actually, the source of pain is the annular tear. And we're cleaning up the annular tear so that it can heal and not be painful. So there's that's something that people sometimes ask about. It's very complicated because this is the only place in the world that does it, so you're not going to hear about it everywhere. But that's the idea. We're actually fixing something that's really almost not even seen on an MRI scan. It's barely visible on the MRI because it's so small. And that's the problem, is that most surgeons don't appreciate the significance of such a small abnormality, you know? But it's pretty silly if you think about it. Like, if you look at a plaque in a coronary artery, so the artery that feeds blood to your heart, if you look at the plaque, it's microscopic. I mean, you can barely see it. But it can kill you. An aneurysm. Oh my God, we're talking about something that's a few millimeters. Can kill you. How's our blood pressure? All right. So small things can be very bad. And unfortunately, most spine surgeons are too stupid to understand that. Small things can be very, very, very powerful. Who are you talking to? Who are you talking to? Yeah. Yeah. I'll second that. Shot. All right. So, sorry, we need to have a little bit of operating room humor. Shot. I need to put a little elbow grease into this. Shot. There we go. So the reason I had to put a little elbow grease is you got to force the herniation back in. And the herniation a lot of times is pretty scarred up, like right to the annulus. So it's stuck there. Doesn't want to move. Shot. Very good. So this will be our last Deuk Laser Disc Repair procedure here at L34. We know all 3 discs were causing her pain. If you joined us late, we did a discogram about 30 minutes ago, and we tested each disc, and you can see the one we're about to fix, this L34, was 10 out of 10 pain when I stimulated it. 10 out of 10 means the worst pain in your life. It's like serious pain. I mean, it doesn't go any higher than 10 out of 10, obviously. Honestly, a lot of these patients that deal with this pain every day, they have to modulate their behavior. They literally have to not do anything so they don't bring on that 10 out of 10 pain. But, you know, we unabashedly elicited 10 out of 10 pain because we wanted to see just how bad the pain could be at this disc. And the truth is, you know, somebody like this with a 10 out of 10 disc could go and start bending and raking leaves at home and picking up garbage or whatever, and then they're going to pay for it because they're going to have severe pain afterwards. It could last days. So these people with chronic back and neck pain, they end up not doing anything strenuous or active, and they end up getting fat and diabetic. So, you know, people don't really appreciate, unless you have chronic back pain, just the impact that it has on people's lives, and it needs to be fixed so people can go back to being active and normal and healthy, and probably eliminate a lot of the diseases that we have as a result of obesity and inactivity. So this is on a huge scale. Yeah, there may only be 120 million people worldwide with chronic pain, but those people have a lot of other conditions. Okay, we need irrigation, guys. Why is there no irrigation? Did you guys take a vacation? Huh? we got to call HR. Oh, sorry, we're just being silly. All right, there's a piece of herniation right there. Okay, and I shoved that guy in from the outside. Look at that thing. Oh, yeah. Oh, yeah. Do we have any questions?
I do
Oh
have
my
one.
God, you gotta stop killing the mic like that. Who's assaulting the mic?
I'm not sure what you mean.
Is that Sean?
Yeah, it's Sean.
What did the mic do to you?
I'm
Just
not sure.
kidding. All right. Do you have any questions?
Yes, a viewer from Facebook is wondering, how many years did it take for you to become a surgeon?
All right. How many years did it take for me to become a surgeon? That's a really, really good question. Isn't it funny how every question I just can't give you a direct answer? It's because it's complicated. I mean, that question, the way it's asked, is a little bit open-ended, so it kind of leaves it to interpretation. I mean, if you really want to know, it started when I was 5 years old, you know, getting good grades in school. When everyone else was going out having fun, playing in the playground, or going out and riding their bikes, or playing with Barbie dolls, I had to sit there and do math and science and do enough of it to get an A. So yeah, it started when I was young, obviously with good grades, and then that carries forward to high school, getting really good grades, and then getting into a really good college and getting, you know, straight A's, and then going to medical school for 4 years. So college, I did college in 5 years. It took me a year longer. Why? Because my father died when I was a freshman, and it just really wrecked me emotionally. So it took me a year to recover and kind of get my grades back up. Then I went to UC San Diego for undergrad, and then I went to USC in Los Angeles for medical school, one of the best med schools in my opinion in the country. I don't know how their curriculum has changed over the years, but that's 4 years of med school. And then after medical school, to become a neurosurgeon, you can either go to a 6-year program or a 7-year program or an 8-year program. But really the most common is 7 years. So for 7 years, I worked in a neurosurgery residency program, learning how to do neurosurgery. And that was at the University of Florida in Gainesville. And I chose that program because Dr. Roten was there, Dr. Albert Roten. He's like a pioneer in neurosurgery worldwide, and one of the most respected neurosurgeons in his lifetime. And he was an anatomist. And anatomists believe that they understand the source and basis of all disease, you know, at least anatomical diseases. Anatomists are like the original doctors that understood disease, because we didn't really have molecular biology techniques, we didn't have DNA analysis techniques, we didn't have a lot of biochemical assay techniques, so we couldn't understand the biochemistry of disease back in those days. It was just everything was anatomical. It was like, oh, there's a big tumor, take it out, you know? And so now we understand that many diseases have a genetic basis that you can't see. It's not anatomical. You know, they may manifest themselves anatomically later on, but they start with an abnormality of the genetic code, which is something that's way beyond microscopic. You can't even see it with a microscope. So I guess what I'm saying is the reason I went to UF in Gainesville was it was the top neurosurgery program in the country for training at the time. But that took 7 years. So when did I become a surgeon? It's hard to say. You know, did I become a surgeon the first day of my 7-year residency? Did I become a surgeon after I graduated? I mean, you actually are doing surgery during your residency. So I would say you really become a surgeon the first time when you graduate med school and you start your surgery residency. So how long did that take? It took me from elementary through high school, 5 years of college in my case, and 4 years of med school. Sorry for the roundabout answer, but it's the truth. Any other questions?
None currently.
Wow. Sorry, Sean, I didn't hear you.
None currently.
All right. So we're wrapping up the surgery. We're on the last disc. We've done 2 disc repairs already. We're on the 3rd Deuk Laser Disc Repair, 3rd disc, and we're about to be done. This is good. Now I'm going to show you in just a few minutes that we did the whole surgery on these 3 discs with a 7mm incision. Basically we got into all 3 discs with the same incision. Now, that's one thing that's changed over the years. When I first started doing these surgeries, if I was fixing 2 discs, I would make 2 incisions. When I was fixing 3 discs, I would make 3 incisions. So, you know, that's how I was taught originally. And then I realized, gosh, these incisions are awfully close to each other. Maybe I can do it all with 1 incision. So I think the first time I tried doing that was probably like 2 or 3 years into it. And it was actually, I think, Augusto that suggested I do it. I think it was either Augusto or Roger. Somebody besides me thought about it and said, hey, why don't you try through the same incision? And I'm like, that's a good idea. So I think to be a good surgeon, you have to be somewhat eclectic. You have to be open-minded and willing to try other people's ideas. You have to accept the fact that you don't know everything yourself, and that you're going to learn from the people around you. You have to be open-minded to do that. And the people around you are going to have a lot of really good ideas, you know, and not every one of them is going to be a home run, but you got to listen to them and weigh it out in your mind and see if it's reasonable to try it. There's the tear, by the way. Of all 3 discs we're fixing today, this is the most normal appearing disc. And you can see this is definitely not normal, but it's the most normal appearing one on the MRI. I'm not saying it looks normal, it's the closest to being normal, because the L5S1 disc, the first one we did and the second one we did, are totally collapsed. They're about 80% collapsed. So they've lost 80% of their normal height. All right, we need about 5 minutes and then we're going to be wrapped up, and we have Dr. Patel do his little part. Is he aware? And is he here? Oh, perfect. Perfect. By the way, this is all scar tissue from the annular tear and chronic inflammation. Stand by. I got to get that little piece out. So you can see how little I actually use these grabbers. Other surgeons that do transforaminal surgery, they use these grabbers mostly. They don't really use the laser very much. And I can tell you, a lot of companies that advertise laser spine surgery, they really don't even use the laser. Of course, they'll never tell you that or show you that, but they use it as a marketing gimmick. But here at Deuk Spine, we actually really use the laser for the whole surgery. It's an important distinction. You can see the tear down there. That's the lateral part of the disc. Remember you were asking me if I can look around the disc? That's it right there. We're just about done, but I know Dr. Patel will be in to do his part real quick. Pressure still good? I meant the saline irrigation. But I'm glad to hear that the patient's blood pressure is still good. By the way, that's a herniated disc right there, the blue stuff. Once again, you won't see this surgery done anywhere else in the world. It was created here at Deuk Spine Institute, pioneered here. Of course, there will be surgeons who start to copy what we do, or try to at least. And that's fine, as long as they do a good job. All right. We're getting close to the last part of this herniation. The last part of the tear. You can actually see to at 3 o'clock, or sorry, 9 o'clock, the end plate of L3. No, sorry, L4. Because this is the 3-4 disc. Grabber. And this stuff is just really scarred down. This is nucleus herniation that's just scarred down. I'm sitting there zapping it with the laser, and it's not getting rid of it. So I'm going to try to get rid of some of it the old-fashioned way. Grab and run. All right, that's about as much as I could do the old-fashioned way. Not very satisfying, by the way. Any other questions from our audience, Sean?
None currently.
Okay. There we go. We're outside now, right at the exit of the disc. You can see at 12 o'clock there's some epidural fat and veins, which are all normal things to find in the epidural space. Just going to zap this last bit of herniation away right here. This is just underneath the posterior longitudinal ligament. Deuk Spine Institute does have a Facebook Facebook group. You can look it up. It's free to join. It's called the Spine Surgery Support Group. And Sean, I'm going to have to take that back over. So just remind me if you could.
Will do.
And then also, you know what, let Joe know about it as well, so he can contribute or start contributing. All right, we are pretty much done. I'm done here. Is Dr. Patel ready? Okay, but he knows he's on his way as soon as he's done. All right. Yeah, that'll give us time to put the Band-Aid on. You see him? No? That's fine. I thought you said he's there. No, he will be. Oh, okay. All right, any last minute questions? Type them up. I'm going to go head over to the camera and I'll do a quick recap of some of the stuff that we talked about for you. And I know our next laser surgery is going to be here shortly, if not already. And our next patient is going to be another 3-level, but we're actually doing 1 disc on the left and two discs from the right side. That's a little bit of fat. That's nothing to worry about. I think we've gotten everything we need to out of this patient's disc that needs to be repaired. I'm pretty happy. So we're done. Scope off. All right, now we're going to show you the incision. Can you zoom in here so you can see it?
Yes, we can.
All right, so first of all, this is the scope that we use. Can you all see that? You've got a light source here that actually is turned off, but it normally has a very powerful light, and it shoots the light here, which goes down through a little fiber optics to the end to light everything up down here. We have a tube And this is called a rod lens system because there's a system of lenses in here that allow me to see using the camera. So if we take the camera off, this is the camera. It's a funny looking camera, but that's a camera. It's an endoscopic camera, and you can actually see there's a glass window there, and that's what the camera grabs that image from right there. So the image is brought from the end of the scope here through a series of lenses. It's bent, and it goes into the camera. Pretty standard endoscopic stuff. There's nothing unusual or different about that. But this endoscope here is built specifically for the spine. There's an irrigation source right here and an irrigation port. And I already told you about the light source. And here's the actual scope itself. Part of the problem is these little things like this are very expensive. They run about $13,000, $14,000 now for one scope. So it's there, everything is expensive here to buy, which is why a lot of doctors and hospitals don't invest the money. All right, so we're going to take out the tube out of L3-4, and we're going to put a little pressure. Why? Because sometimes the muscle oozes a little bit. So we want to give that a few minutes. And I'm going to show you the incision right now. Can you guys see with enough light here?
Yes,
Sean?
we can.
All right. So you see right there, there's the entire incision. This is a finger, that's the incision. All 3 discs were fixed with that little incision. That's why these patients can go home right after surgery within 30 minutes. That's why there's no blood loss. That's why there's no damage to the body, because it's such a minimally invasive surgery. Remember, we didn't take any of the spine out either. We didn't take any of the bones or ligaments in the spine out. We didn't damage them in any way, unlike traditional spine surgery done elsewhere. All right, go ahead and type up your questions, and I'll be over there in a minute or two to answer them for you. Great job, everybody. Thank you. Nice work, doctor. Are we live? All right, I'm Dr. Deuk Laser. I just finished up this surgery that has gone very well for our patient from Canada. Yet another patient from Canada. We did a lot of patients from Canada. Canada doesn't have this technology with the endoscopic Deuk Laser Disc Repair. As a matter of fact, it's only done here near Orlando, Florida in the United States at Duke Spine Institute. This is our only location for the time being, so this is the only place it's done. Everybody travels to come here. Our next patient is traveling from out of state as well. He's from Pennsylvania. I was just talking to him in pre-op, making sure he's ready for surgery. He is. He's going to be a 3-level as well. And what does a 3-level mean? Well, if you look at the spine, okay, you can see that the spine, and these are pretty much representative of actual size bones and discs in the spine. And this is the lower part of the back. This is called the lumbar spine. Of course, if you're dealing with the cervical spine, it looks different. Oh, this is the cervical spine, and this is the lumbar spine. Cervical, lumbar. Can you guys see that okay? And look at the difference here. Look at the bones in the cervical spine, how small they are compared to the bones in the lumbar spine. The bones in the lumbar spine are probably at least 4 times bigger. Why? Because the cervical spine or the neck, okay, it only has to hold up your head plus your arms, like what you're carrying. So all the muscles from your shoulders and neck, they attach to the spine, right along those bones, okay? But the lumbar spine, it's got to hold up everything above it and all your organs. They all attach to the back of the abdominal wall, and all that weight gets attached to the spine, like that, okay? So it actually pulls down towards the ground when you're standing and walking. Very simplistic, I know, but don't criticize me for explaining it that way, but that is the case. Long story short, the patient we just did surgery on and the patient we're doing surgery on next both have 3 disc injuries. And if you take all patients around the world that have back pain, the number 1 disc that's going to be the most common cause of their back pain is this one right here. It's the L4-5 disc. This is the L4 bone, the L5 bone, and then this is the sacrum or tailbone. So the disc between the L4 and L5, the last 2 vertebrae really in the spine, that disc is the number 1 cause of back pain right there. And it accounts for probably at least 70% of back pain. The next most common disc to cause back pain is this one here, the L5S1. So remember I told you earlier in this broadcast that most patients with back pain, it's coming from 2.5 discs. So, you know, they either have this disc and this disc causing pain, or this disc and this disc causing pain, or all 3 causing pain. Rarely ever do we see L2-3 causing pain. So the vast majority of back pain comes from the L4-5, the L5S1, then the L3-4 disc. And that's what we're doing both of our surgeries on today. What you're seeing here is screws and rods. That's not part of the Deuk Laser Disc Repair. That's just to show you what a fusion would look like. When you fuse 2 bones together, take a look at the spine. You can move your spine and laterally bend. So if you're bending side to side, you're actually laterally bending like this, okay? And what's moving is the discs are moving at the disc, and you're also moving in the back of the spine at the facet joints. You can see it right there. The facets move with lateral bending. With flexing and extending, that means you're flexing forward, extending backward, flexing forward, extending backward. You're doing this with your lower back. Forward, backward, forward, backward, forward, backward. So again, your facet joints are moving and your disc is moving. So really what the disc and the facet joints are, they're just joints between bones. And the disc is just a giant cushion, because if you look at the weight distribution through the spine, all your body's weight above your belly button goes down through the spine, okay? And 85% of it goes through the discs. 85% goes through the discs. 15% of your weight goes through the facet joint. So the reality of it is that the discs take 85% of your weight. The majority of the weight of the body is just crushing down on those discs. So they have to be really good, like hydraulic cushions. And that's what they are, until you get a tear in the back of the disc from trauma. Let's say you're playing football or golf and suddenly you swing or you get traumatized. You just rip the fibers in the back of that disc. And that rip in the fibers, then it's going to allow the jelly that's in the center of that, it's going to allow that jelly to squeeze up through the tear. And when that jelly gets wedged in there, that's where all the pain comes from, that tear and the jelly in there. That's what we're fixing with the laser surgery, the Deuk Laser Disc Repair. The surgery that we created here. I come in, I go deep, I push the herniation down, then I start here and I literally work my way back and pop out of the disc, and I laser clean all this stuff up. And that's what our surgery is. It's that simple. We do that for 3 discs in this patient. And that's what we're doing in the next patient. So we'll take questions.
So our first question comes from a viewer on Facebook who's wondering, what are some of the symptoms of fusion screws starting to back out?
So the first person said, what are the symptoms of fusion screws starting to back out? These are fusion screws in the lower back. You can see the screws. They're embedded into the bone, and they're held in there with a rod, okay? And if you do fusion screws in the neck, this is what it looks like. It's usually a metal plate with little screws in there. Now there is another fusion system for the back of the neck that we use that also involves using rods and screws, okay? So there's screws and rods that go in the back of the spine to fuse, and generally in the front of the spine we use metal plates with screws. So what are the symptoms of screws backing out? Well, to be quite honest with you, I've never seen a screw back out, even in my patients or other doctors' patients. I've never seen a screw back out in the lower back. You know, here's why. This screw cannot back out because the rod is holding it there. So the only way this screw and this screw can back out is if they start twisting out, but that's not possible because the rod's holding them. So screws don't really back out, but they do get loose. They can get loose inside the bone. And if they get really, really, really loose, they could back out. But again, I've never seen that happen, ever. And this is all I deal with. Now, I have seen screws in the neck back out. I've seen the screws here in this metal plate. If you look from the side profile, you can see their little nubs. Those screws could back out. And so I don't know if this viewer is talking about screws backing out in their neck from an ACDF or screws backing out in their lower back. But I've never seen screws back out in the lower back unless they're talking about them just being loose. So I'm not really sure. But what are the symptoms? I mean, you can have pain, obviously. But here's the problem. I get a lot of patients who call Deuk Spine Institute and they say, hey, I had a fusion done, I got screws in there, and I'm in pain now again, it's worse, and the doctor wants to take my screws and rods out because they're causing pain. I've never seen the screws and rods cause pain in a patient. When doctors tell their patient that, they're basically lying to them. The screws and rods don't cause pain. I mean, the chance they cause pain would be extremely unusual. Like if it was sitting on a nerve root, for example, and you had pain down your leg or down your arm. Only then when the screw is actually sticking in the nerve root, which honestly, even many of the most incompetent surgeons in the world don't do that. They're decent enough, they don't do that. Like we all know where the nerves are. So I don't know what's going on with your back and why you're saying you're having symptoms of the screws backing out, but I would say the more likely cause of your symptoms is that you have a problem above your fusion or below your fusion, with the disc above the fusion or the disc below the fusion. That's more likely the cause of your symptoms. Of course, you could have infection. I don't know how old your surgery was, but typically surgical infections happen usually around 2 weeks after surgery. If you're going to get an infection, they present 2 weeks after surgery. It's extremely unlikely that surgical infections happen before a week after your surgery. So just something to keep in mind. If you want to send Deuk Spine Institute your MRI and do the free MRI review, we'll take a look at your MRI and I'll let you know why you're having pain. But I highly doubt it's the screws backing out. Next question.
Next question, another viewer on Facebook is wondering, what are the symptoms of having a hematoma after surgery? How would you feel? Where would it be located? And how long would it last?
Great question. Sorry, I have to eat my coffee beans because my staff didn't get me any coffee. Hint, hint. So, hematoma. What is a hematoma? A hematoma is basically blood that's outside of a blood vessel. And blood is normally not ever found outside of a blood vessel. Now, sometimes we cut ourselves and we see the blood come outside, and it's outside on our skin or on our body. That's not a hematoma. A hematoma is blood that's outside the blood vessel but inside our body. Now, some hematomas, like bruises that we commonly see under our skin, they're totally benign. They don't cause any problems. Okay? And then there's people who have blood clots that, or hematomas, blood clots, that form internally that could be very problematic. Okay? So we have to understand that not all hematomas are bad. And anytime you do surgery on a patient, there's going to be a little bit of hematoma that's in that area that you operated, always. The goal, though, for surgeons is to minimize that amount of hematoma. And of course, to make sure that whatever hematoma is there doesn't cause symptoms. So the question that you've asked is a very good question, but the answer is complicated. And the reason it's complicated is because it really depends on the size of the hematoma, and it depends on the location of the hematoma. And you can have a relatively big hematoma or blood clot inside the body that doesn't cause any symptoms at all. And you could have a small hematoma that causes paralysis of the body. So a hematoma that happens, for example, in the neck, called an epidural hematoma, because it's formed inside the space right here outside the dura of the spinal cord, that hematoma doesn't have to be big. It can be small. And that hematoma could cause someone to be paralyzed. I actually treated a patient with an epidural hematoma that was paralyzed. The patient had gone to a pain management doctor, and that pain management doctor forgot to take the patient off of their blood thinner before they stuck a needle in their spine. And when they put the needle in the spine, it nicked the vein, and that vein bled inside their spinal canal. And that blood clot got bigger, and it just pushed on the spinal cord and paralyzed the patient. So, of course, they called me to come save the patient, and I did. I went in and I did surgery. I had to open them up, take all the bone and ligaments out in the back, suck the blood clot out of the spinal canal, and the patient did okay. But you never want to be in that situation. It was really stupid of the doctor not to take the patient off their blood thinner. So that's why when we do our procedures here at Duke Spine, we're always very careful to make sure patients are not on blood thinners. All right? Now, you could have a blood clot with the surgery that I just did, and it could be in the muscle, or it could be under the skin, or it could be around the nerves. If the blood clot forms around the nerves, it could cause the nerves to stop working. And then you need to go in and take it out, take the blood clot out to get the pressure off the nerves so they can work again. If the blood clot is in the muscle, then generally it just causes pain and discomfort for the patient. And that pain can last weeks because the blood clot breaks down, like it gets dissolved slowly over time by the patient's body. And when it breaks down, unfortunately it releases hemosiderin, and the hemosiderin is very irritating to the muscles and causes inflammation. So a hematoma or a blood clot within the muscle can be painful. And then, of course, you could have it under your skin, which is not that big of a deal unless it's really big. So it really depends on the location and the size of the blood clot to really know what kind of symptoms it's going to cause. I hope I answered the question. I know it's a bit of a general answer, but the problem is I don't know exactly what kind of blood clot you're talking about or how big it is. And so I try to keep it more general. Okay?
And the last question comes from our longtime viewer, Sue Griffin, who's wondering, Dr. Duke, how's your son's racing going?
Hi, Sue. Thanks for watching. It's always a pleasure to interact with you. Arias's racing is going very well, and it's not going well. Here's why. Driving-wise, he's amazing. Unfortunately, the politics of formula racing in the United States is pretty bad, and I'm still scratching my noggin. Arias won the first race this weekend on Saturday in Mid-Ohio, which is a professional racetrack in Formula 4. He won the race. but they took his win away because he and another driver, a Canadian driver, were going down on turn one, and the Canadian driver forced Arias off the track, and then they went straight on the straightaway, and then Arias was on the inside for turn two, and then another driver came on Arias's inside, so they went three wide on the exit of turn two, and this outside Canadian driver dropped his wheel in the dirt, and then they said Arias forced him off the track, which is nonsense. It shows Arias is turning his steering wheel in full lock. So he's trying to avoid hitting the guy on the outside completely. You can see that on the onboard video. You can see it in the data. But the stewards, they're pandering basically to the series owner. And the series owner, his name is Perella. He's the owner of SVRA. The guy's a complete idiot. I'm sorry, he's a numbskull. And I don't know why, but he's just, doesn't like Arias for whatever reason. That's fine, but he's taking it out on him. They gave him a 5-position penalty after winning the race. They gave him a suspension for the second race, which is crazy. You lose all those points. Plus, he also had the fastest lap of the race, so he was supposed to start race 2 on pole. But they took all race 2 away, so he lost his pole start. He lost his points for race 2. And because he didn't get any time during race 2 because he was suspended, he had to start race 3 at the back at 27th. So he started in 27th, tried to drive through the pack, but some of the kids spin because they're not very good drivers, and they spun out in front of him and basically knocked his front wing off and destroyed his nose cone. So it was just a horrible weekend in Mid-Ohio, even though Arias was the best and fastest driver on the track. So we have decided that we're not going to race in F4 in the United States anymore, and we're going to submit a formal complaint to the FIA about the stewardship, who are supposed to be the judges of facts, but they didn't bother to look at the videos. They didn't bother to look at the data. They just listened to the owner, who was screaming and yelling that all this contact during the race is going to make people upset with him and put him out of business. He's losing money. That's what he told the drivers in the drivers meeting. I'm losing a lot of money because you guys keep making contact during racing. You got 27 cars in this big of a space, all hitting the accelerator at the same time. Of course you're going to have some contact. Anyway, yeah, real disappointing, but we're going to be coming to Europe and racing F3. I'm starting to try to contact teams for him and get him some test days in Europe. We're looking at running Freca, which is the Formula Regional European Championship that's in Europe next year, versus FAA F3. So I don't know what we're going to do yet. They're all very expensive. We just got to look at our budget, and hopefully he could impress someone like Red Bull that they're going to want to keep him as a driver, which I think will happen once they lay eyes on him and see just how good he is. Thank you for asking. Any other questions? All right, we'll see you back in about 30, 40 minutes for our next live stream. Thanks, Sue.